How are you?
Good, good, Dr. Sarkis. How are you?
Good, good, good.
You look nice. You look very nice.
Oh, well, thank you very much. Thank you. I see people in their beds enjoying themselves. Just don't fall asleep over at Kim, okay? How are you, Noel? Good. Excellent. If you, I just want you to make sure they're all here clearly. So that's very good.
Yes.
We'll wait another couple of minutes before we start. There's about over 160 people have been registered, so
okay.
We want to make sure that we have everyone on board. This is a very interesting lecture. I have my good periodontal colleague, Dr. Esa Malat, who will join us soon. So there's a lot of people coming on board, so I hope you don't mind just waiting a bit longer. Isidoro, how are you?
Very good, Sarkis. How are you?
Good. You had a good day. Oh, you look just the part. Can you just part of your head, please? I'll go. Huh?
You like it?
The matches connecting. Hey, you look awesome. You look really good. You know, very
good lecture. Thank you.
Yeah, very, very impressed. Very impressed. That's good. That's good. That's good. I like your picture, Dinesh. I wonder who took that picture of you.
A wise man.
Looking good. Looking very
I wonder if I can see myself.
Easy, are you still at the surgery?
Oh, yeah.
Always, always, always.
Oh, don't be that dedicated.
One of the most dedicated dentists I know is Doris.
I can't see myself here. Watch out, you'll burn yourself, huh?
I know. Stop video. Stop video.
Can we reduce the noise back, please? Guys,
and then mute yourself.
No children, please. Please, no children. You need to hear the lecture, so make sure the children are not around. I do apologize, or mute yourself. So that is important. Okay, we've got some very good, interesting people coming in, and some new people coming in. I'm very pleased. Now, did you read that? Very good. Any questions so far? Nimesh, how'd you go with your cases?
Which one?
The one you showed me last time.
She's coming tomorrow, so I'll be waiting to have a quick mock-up in her mouth and have a quick chat about the options. I need to look at how we can do the ortho and stuff. I think that's the main thing. So ortho is going to be critical part, whether we do ortho or we just go directly restorative. So
okay, well, that's good. So did you open the bite, do all the things that you normally do, you know what to do?
Yeah, yeah.
You know what to do, so that's important.
How's your day?
I had all diagnostics. I had all diagnostics today, so it was quite just interesting because I had to. Sometimes it takes time. You know what you do. I mean, it takes time, and so I'm just going to start to share my screen.
I had a very interesting case of external resorption. With 1121, you know, and
right. You can see
tricky.
Screen, right? You can see the screen.
Yeah, I can see the screen. Yeah.
Okay, you can see the lecture here. Yeah.
Yeah.
Good. That's awesome. And I got lots of things. I'll just talk a little bit about the. Any questions about the college, or I can talk at the end. Anyone who's got a question for college at the moment before I start the lecture? No one? I'll wait a little bit longer. Where are we? That's the case we're discussing today, and that'd be a very interesting case today to discuss. You're all wondering how we're going to treat this patient, aren't we? And I know what a lot of you are thinking. Hope to give you another way to look at things. Remember that you know, treatment can be done, there's only one diagnosis and many ways to treat cases. So one of the reasons I'll bring this case up is to just improve your lateral thinking, because we all used to things, we all used to doing things certain ways, but we don't have time to reflect. I've been a clinician for a long time. I have considerable experience and made a lot of mistakes. But the most important part is I've learned with mistakes, and you got to learn from your mistakes. And minimum motivation is the key in many of these cases. I'm just waiting for Esan to come aboard. Esan, are you on board? Okay, I'm just waiting. Any questions?
Dr. Esan will be here in about a couple of minutes.
Okay, good. So any questions about the college? That if you have, let me know. Now I can answer one question, but I want to get on with the lecture, and then we can answer later on if you like. But,
There's
So
one
there's-
question in the comments,
Right.
and that's, give me a second. It's who is the course targeted at?
Say again, I'm so sorry I didn't hear that.
Who is the course targeted at?
I can't hear. I'm so sorry. Can you say again? What's the course? Sorry.
Oh, I'm sorry. The question is, who is the course targeted at?
The course is at the moment. Natasha?
So
the
Sarkis,
question is
who-
that
Yeah, sorry,
what is
Kevin,
the
you can
course
say.
targeted at? So what they mean to
Okay,
ask
what's the
is,
course targeted at? I'm so sorry. So I didn't even start it. I'm so sorry. The course is targeted to all level of clinicians. Now, there are clinicians who just graduated, and they have certain things that they understand, but they like to learn more and to be able to condense their knowledge and have a good practical clinical skills, like critical skills to be able to use in their practice. The whole course is also good for students who have been out for a few years because they have some experience, but they realize that certain things work and certain things doesn't work, so they want to see why it doesn't work, okay, and also why it works. So we don't tend to learn from when things go right. You always need to learn when things go wrong, but also you need to understand why things go right. So that's very important. And also, of course, it's open to advanced and more experienced clinicians because, as I explained early in the lecture program, I was lecturing overseas and talking about the risk assessment and all these complex cases. Someone said to me, you know what, I've done this thousands of times and, I keep getting it wrong. I said, well, maybe you've done 1,000 times wrong. So the issue is that to be able to challenge your thought pattern, to be able to think about, well, okay, could I have done this case better? Or how else could I have done this case? And I challenge myself every day about this. I look at myself, could I have done this case better? Was there another way I could do this case? And that's what clinical dentistry is all about, because you're learning different ways to think. And I get terrific, for instance, ideas when I talk to colleagues, and I mean, because of COVID, you can't go anywhere. When you're in the different conventions and someone has a really good clinical case study, you watch what the other clinician does, and you learn a few tips, and you can sort of, after a lecture, tap on his shoulder and says, I like your case, can you tell me how to do this part and that part? And that's very important. Unfortunately, Natasha, you asked a good question in terms of today, we don't have anyone that we can sort of call or get on the outside of the phone or write a mentor to actually hold your hand while you're going through this important, knowledge learning and application knowledge learning to get those critical skills in that process. Universities, I think we talked about bridging the gap in dentistry, and that's really what it's all about. We are bridging the gap in dentistry. And if there's any prosthodontists in the audience, would you please come up and comment on this? I'm happy to any of the cases. And if it's periodontists, love to hear your comments on this as well. And the important part is to make you think. See, we make you think before you start the case. And when things do go wrong, we say, what did we go wrong? So when I'm showing you cases, these cases are very carefully selected. They're very carefully selected to teach you. And in the college, it's not just a simple concept. This college is about giving you a postgraduate diploma that's UK qualified. We went through a stringent process to get this qualification to be able to issue postgraduate diploma. It's not a BDS degree. It's many times higher than BDS or doctorate. in clinical doctorate in initial, like new doctors that issue to undergraduate students. So it's a lot more higher than that. So when you tell me, oh, look, I know about partial there. Yes, I know about root cause. You really, I mean, let me tell you one thing. It's a continual learning process, okay? When we talk about certain things, and I will challenge your ideas, the only way you're going to learn is if someone actually challenges you in your knowledge. So this course will challenge you, this postgraduate diploma, in how to think. And then when I challenge you, I say, what would you say that? I mean, I've Natasha been with for the last 3 years, and I've always challenged your thought pattern. I think Natasha can comment how much it's changed you in terms of how you look at your cases and how you sort of diagnose them. And, you know, I can also say Natasha is a medalist at the university, so top student. And what I'm trying to do and aim and target this course is for those who feel they want to learn more and improve their clinical skills, and having specialists who really mentor you. There's a lot of courses given by non-specialists. Well, that's fine. But this course is given by specialists, and they're highly qualified in their field, well experienced, and we give it to you, we share our knowledge with you. And those are two different things. That's why I say think like a specialist, because you can think like a specialist, they can do your clinical dentistry like a specialist, say in practice like a specialist. And when you build up your clinical skills, you will see a different level, and that's important.
Dr. Saki, someone's asked a question regarding the new short course that's coming.
I will talk about that short course very soon at the end of the lecture, and I'll
Sure.
play that initial video. I'm happy to do it. But with everyone's permission, may I proceed? Is Ehsan, may I
Sure.
proceed with the lecture? Ehsan, are you there?
Yeah, he's here.
Fantastic.
Yes, I'm here. Can you hear me?
I can see you and hear you, Ehsan. How are you?
All right, excellent. All right, excellent.
Very
Good.
Okay, well, Ehsan, you're part of the faculty, and you'll be presenting a few lectures to the faculty as well, which
Yep.
I'm grateful for. Now, this is the case, and you can see typically the question was asked if the patient wants a fixed option. In this case, it's not 39 years female. I apologize, it's actually 53. Now she's about 63. By the time she came in, she's about 50. So I made that mistake. I apologize for that. But same questions, you know, what's a fixed option, diagnosis, treatment options, short-term, long-term, what factors do you consider? We've got failing teeth. So this is a typical case scenario that may present in your practice. And this happens in my practice every day, not necessarily referred by a general dentist, but also referred just from, you know, patient inquiries. So, Ehsan, I welcome you to the practice, to the webinar. And
Thank you.
And Ehsan is a specialist periodontist, a very clever thinker. I love the way you think, and I like your philosophy. And to me, that's very important. I think, Ehsan, you did periodontics to save teeth, right? Not just
That's right. That's right.
Is that correct? Because implants don't have a periodontal membrane. We just have to get that straight, okay? And George Zarb said implants don't have a periodontal membrane, but teeth have, okay? We have to get that right, I think, to our colleagues that I understand. And so without much ado, I'm going to go with the case, and you can see this particular patient here. You know, we have a advanced chronic generalized periodontal disease. You can see there's a bonus right around. I haven't marked it, but Ehsan, maybe you want to comment on this, and I'll continue.
Yep. So from what I can see in the OPG, there's advanced bone loss pretty much all around. How old was the patient, did you say?
At the time, she was about 45.
Yeah. So this is pretty advanced bone loss for that age. And I can see furcation involvements grade 2 or even grade 3 at some areas. Most likely there will be some degree of mobility. I can see some subgingival calculus. So basically it's a full-on perio case.
Exactly. And when you think about this case, for instance, just before we speak, can you please mute, because Kevin, please remove the person whose sound I'm hearing right now. Would you do that? Just remove the person, please.
Okay.
Do it now. Because the 7 class has to go. Okay, thank you. Thank you so much, Essam. Let's
No
talk
worries.
about this case. Naturally, what I find talking to my colleagues, patients coming like this, the first advice patients given is basically a full mouth clearance and 6 implants on top, maybe 4, or 4 implants on top, maybe 6. And when you're looking at a patient who's 46 years of age, my thought pattern is, if this was my sister, would I consider full mouth clearance? Sometimes you have to sit back and say, okay, here's patients like your wife, your sister, would you consider full mouth clearance? And that's something to me is a key indicator in my treatment planning approach. What is your thoughts on that?
Yeah, fully agree. Well, basically, for all of these patients, they should be presented with options, and there's always option of implants, on the table. But the thing is that that's generally the ultimate option, because there's no basically going back from that. So the problem with these patients that they come in with pretty much like a full dentition, like this case. And then we see advanced bone loss everywhere, a lot of mobility, a lot of issues. So basically, a lot of teeth with questionable prognosis, or some with poor prognosis. So for many of these patients, going from this full dentition to full clearance and implants all on X, for example, it's just a too big a change, and so very frequently we find that it's just that doesn't fit into the patient's lifestyle, and they're just not ready for that. So there will be a minority of patients that may choose that option, and or it may be suitable for them, but there is I suppose patients have to be presented with options. And I personally, in my practice, which is we've give the options of saving teeth to patient, and feel that they deserve to use their teeth for much longer.
Absolutely.
There's actually I would say very few patients that choose to go down the path of full clearance and implants, knowing that the other options are available, at least for some time, and that some time can be up to a decade, and that can mean a lot for the patient, and that they can actually get mentally, financially prepared for that final transition to a full dentalism and implants.
You hit the nail on the head, because I can tell you one thing: you can't do all on 4 in this patient that simply. There's a lot of bone loss. There's a lot of issues. There's going to be a lot of destruction here. Okay, and we'll talk about it later on, because at age 46, you take teeth out for implants. Well, average implant span, let's say, the success rate is less than 9.8 years, whatever. But don't forget, there's a lot of problem with all the statistics, and there were a lot of failures in between. So Paulo Model's case and all the data, there's a lot of issues with the papers, and we all know that. Okay, so what happens? I mean, implants are an artificial device. Put in a bone. There's this bioactive material, depends on the bone response, depends on the level of the immune state of the patients. And what happens, you buy 10 years time, but teeth been there for centuries and billions of years. It's an evolutionary process. There's a periodontal membrane, they need a chance. So that's the important point you've mentioned. Look, let's keep moving, because that's what I was saying. I mean, my question is, which teeth are at risk? Can someone in the audience answer this question for me? Which teeth are at risk of further bone loss? Anyone?
All of them.
Well said. Easy, you get 100. I mean, you're gonna like this guy, huh? Here's my protege, right? Izzy, thank you very much. You nailed this. Okay, you see, you know how to look at the case. All of them, absolutely. Well said. So what happens when the patient presents with this, with this situation? I mean, where do you go? Patients, in this particular case, We lost some teeth naturally. She's about, we've maintained as much as we can. I think she's probably about 50. And we look at specific risk factors. Naturally, there's a problem of aesthetic disturbance. For those of you who don't know what aesthetic disturbance is, it's aesthetic disturbance is that either to the observer or to the patient, thing doesn't look right. She's in the public eye, very important person, and we have a problem. So the issue is, how do we look at the risk factors? And you know, it's always unrealistic aesthetic expectations. I mean, higher lip line, high smile line. This is a nightmare. So if you lose his teeth, you're going to have this big defect that's very hard to restore prosthetically. I don't like being a hero, and I don't like surprises. There's gum asymmetry. She's mesocephalic, facial development, digital thin biotype, a lot of bone loss, okay? And there's a lot of horizontal and vertical bone loss, so there's a little vertical defect here. So in many ways, all the teeth are compromised, like Izzy, you said, you're on the money there. And you said missing 1-1, and the posterior molars have been lost, and looking at occlusal factors, and on top of that, patient's a smoker. But she's had the surgery every 3 months, having teeth cleaned. So I would like to say about a year ago, she stopped smoking. But that's a long time later from this image. But you can see that she's always there for a regular dental checkup and regular cleans. Now, having said this, remember the original plan. How did we plan? We control, stabilize, then we go ahead and reassess, then we go diagnostic phase. Then we also reassess our diagnosis, make sure we have the right diagnosis. And once we finish, we do a definite treatment. And then we go back maintenance. Maintenance starts on part 1 here. So it's important to understand, think before you do anything. Take your time. You're not ready to treat this patient, that's fine. Talk to another colleague, talk to another specialist, sit back, think about your case. So this is a year later, that was 2006, a year later. You can see that for some reason, we have quite advanced bone loss, and we have more advanced bone loss in the 7s, okay, and the 7s and the 6 here, 1-1. So we're starting to get a problem with this patient. You know, what I would normally say is, first I said, how are you? How are you feeling? Oh, look, I haven't been very good. I've been hospitalized. And, I haven't been ill. I've had to take this medication. You look at the medical history of this patient, definitely polypharmacy. It's got cardiovascular heart issues, okay? And periodontal disease is part of the whole cardiovascular chain, immune chain. And it's important to understand that we have a patient who's got a very major compromised medical condition, ASA 2/3. And what do we do for this patient? When we think about extracting teeth and placing implants, is that the right time for this patient? Okay, so that we have a change in risk status, okay, and the biology is compromised. So we are dealing now already with a compromised biology, not just teeth, but also, we've lost those teeth, as you can see, all right? Not just teeth, but also overall general health and gum care. So your role as a dental surgeon is to maintain the health of the periodontal tissues. Why? Because we want to reduce the biomass, the biological markers for inflammation. I think I might allow Ehsan to come in, and Ehsan talk about the biomass reduction in plaque and how does it reduce the inflammatory markers in the blood. Would you make a few comments on that, please?
Yeah, sure. It's patients medically also not in a good situation, being 40-something years old and having already had cardiovascular disease. What type of cardiovascular disease, patient?
She got heart problem. I think she got I'll tell you, coronary artery disease. Okay.
Yeah, well, with someone with advanced periodontal disease, there's a significant increase in the inflammatory markers in the bloodstream, and that's that can affect all their organs.
Exactly.
And that's a risk factor. There's with cardiovascular disease, that's they check the inflammatory markers. That's something that comes in the overall management of the patient, and so it basically the management of periodontal disease and the cardiovascular disease sort of comes in hand to hand. So and then one affects the other, and vice versa. So it's it's very important to look at the whole picture and
Exactly.
yeah.
So when the patient presents, let's say in the initial stages of advanced periodontal disease, would you consider some sort of blood test to just see if there's other issues such as diabetes and other factors that you want to have a look? Can you hear me, Hassan? I think I lost you, Hassan. Can you hear me?
Oh, yeah, sorry. Can you hear me now?
Yeah, I can hear you now.
Yeah.
Did you hear what I said? Sorry, would you like to repeat?
No, I heard you. Yeah. So basically, at that age mid-40s, if I've got someone with this degree of periodontal disease, and I'm seeing this patient, for the first time, I certainly consider having some blood tests done, because I don't know the history of the patient. I don't know the rate of progression, you know. So it's always good to have a bit of a general sort of medical health screening, just to make sure there's nothing from the general medical health that is affecting the perio, you know, and which obviously need to be controlled at the same time, or to be worked on at the same time.
So Ehsan, I've got the periodontal charts from 2004 all the way right up. Unfortunately, it's in another software called Dentrix, and I'm having a crazy time to retrieve that software. I couldn't do it, so I do apologize to my colleagues if I haven't got period charts initially. However, this is the current charts, as you can see. This is 2014. You still have the lower molars, and this is attachment level for this patient. This is the upper arch. He's lost the molars, and there's an upper arch mobility of 2, 2, 1, 1. Well, and then 1, 2. So, and lower arch you have mobilities of 2, 2, 2, 1, 1, 1. And the patient's been seeing the periodonts in my hygienist. I believe also I have to commend my hygienist for doing such a great job for this patient and maintaining it, and vigorously maintaining the tissues with the injection with the periodontist colleague. Now, the problem is that patient really has a problem. I mean, he's 50 now, and there's been change in her life, teenage, and relationship issues, and the stress. A lot of things are building on patients, and we go for life with lots of things and not just worrying about teeth. But now she's coming back and having a regular SPT, which is supported periodontal therapy. And I asked the periodontist, look, we just want to hang on what we have. So that's fine. And we both want to maintain teeth. But she says, Sarkis, what are you going to do about the look of my teeth? And we get a number of things. And in this particular case is, we want to improve aesthetics, maintaining function, and also confidence of this patient. So we could consider removal of periodontal splint. So I just sit on the tip, close the gums, but that's not really comfortable. But the good thing today, that we look at this very, very carefully. Okay, we know all the teeth are risks, but look at how well she cleans the teeth. That's really good when you think about it, don't you, Ehsan? She really tries hard, okay?
That's right, that's right.
Yeah. So, I'm saying that, what, we can hang on to a lot of teeth. We can hang on to a lot of teeth. I know that the lateral's going to go and the central's about to go. We understand that. We'll talk about some research data soon. But when you look at the patient from a different angle, for instance, I'm looking at, the perio health is stabilized, and we lost the molars, with vacations, and we know that central's about to go and the lateral about to go. So I'll look at the next slide here. And, patient can function okay, but she's really concerned about front teeth just falling out of the mouth. In the case I'm out of town, so whenever it's a long weekend, there's a problem, and I'm not sure what I'm going to do. If you're not here, something happens, I'm in the public eye, and we go and do some reporting. So we have a problem for the patient. And you can see that over a period of time, there's a smoking comes up. So this is still patient smoking at that time. So this is not, she still continues to smoke, which is, increasing risk factors, and we know what happens with time. Now, Ehsan, my question is, shortened dental arch is SDA. I mean, patients got periodontal compromised. That really doesn't work, does it, when you think about it? Shortened dental arch. Like, you know, you can't function with small occlusion because of they're mobile and interesting.
That's a problem when in these situations. Yeah, in these situations we have mobility, and generally we also have fremitus and occlusal problems. So basically, secondary occlusal trauma as well. That's right. That's right. Which then that very much complicates the management as well. So I'm really keen to see, you know, how you addressed all these in this case.
Are you sure about that? Okay, with pleasure, with pleasure. Well, what I did was we call it emergency aesthetics, where I will restore the pink gums prosthetically. And because there's no other way of regenerating gum tissues, I mean, you can forget about any regeneration here, there's no bone. And so we etch the teeth and we add on, you know, pink gums to make it look reasonable. And, you know, a little polishing. I mean, I don't Photoshop my work, I tell you as it is. And you can see with little reasoning, we sort of improve the aesthetic outcome. It's also brought gingival margins. We don't go near the gums to allow the hygiene, but I guess this is better than nothing for this particular patient at this stage, just to get a buy. You know, all we're trying to do is to buy some time, you know, for the patient. And you know, she's 2014. That's 7 years ago, and she's okay. She's happy. We splintered the upper arch, and she can function, and you know, that was time. And we went all the way for another 4 years with this patient to 2018. Simple splinting, good function. There'd been no drifting of teeth. Patient was seen continuously. We adjust the occlusion, and we'll talk about occlusion later on. And you know, we maintain a comfort function of good 4 years. She came regularly. Anybody else want to comment on this? Would you still want implants? Please make a point. Anyone? There's no wrong question, okay? So please ask. Anyone at all?
Can I ask a question?
Yes, please.
Yeah. Is this the sort of a normal smile, or smile, sort of a resting smile of the patient, or is it a
well, she can go a little bit higher. She can go a little bit higher, okay? But where are we?
So this is more like a forced smile. So that the one that's
smile, yeah. Forced smile.
Okay.
So I get referred from lower periodontists to just tie things up while wait for that stage. Okay. 2018, and we just polish them, keep going. And so that's again, forced smile. And so that's 2018. The perio, we lost the central and the laterals. That was gone. So basically, you know, there's enough time. I mean, the problem is, as I explained to you, we went from 2004, okay, to 2018, maintaining comfort, function, aesthetics, just by doing simple and predictable dentistry. Imagine if we placed implants in 2004 or 6, I can't remember what it was. Okay, let's say 12 years ago, how many of those implants would survive until today? We don't know, but we know that we can hang on to the teeth. There's a lot of data on this. Would you agree on that, Ehsan?
Surely, sure, yeah.
Okay, let's go next slide. So, you know, patient goes through, again, difficult times, and we're here to then look at, you know, the question is, why do I need a risk assessment? And people say, well, you know, you keep talking about risk assessment. I mean, why do I need a risk assessment? Well, when you think about this case, this is the current situation. So you can see my pink composites are about there, above supragingivally. There's nothing left. And the problem is that we understood that in this particular case, you know, I mean, patient factors, the compliance wishes. Patient has been very compliant, good 12 years, right? We maintain, sure, this lower arch is splintered. We actually have a special splint on the lower arch. I'll discuss it later. And, you know, is there a tooth fracture? Not really. There's a periodontal problem, so we don't have enough tooth fractures in patients of periodontal disease. Okay, tooth loss, We know it's from many periodontal sites. Oral hardness is improved. Well, vitality, most teeth are actually vital. She has severe sensitivity. A lot of the periodontal patients have sensitivity. You've got attachment levels, restorative occlusion, bone volume, type of bone support, loss of albinus. We have all that. Premolars are still good. Lower canines are very good. And as a matter of fact, I'll show you a landmark paper that says the most important, most teeth that survive the most in all periodontally advanced cases and all patients right across the spectrum are actually the lower canines and also the upper canines and premolars. And so when you think about it, you know, do we need, I mean, I don't think ortho is an issue here, but it's always a consideration. You can do ortho on perio patients as long as the perio is controlled. Would that be correct, Esther?
Yes, true. I think it's probably a good time to get to that famous landmark paper, Hirschfeld-Wasserman, and that's actually pretty much confirming your thought process here. Will you be commenting on that?
Yes, I will be commenting on that. But this is a problem, and then I can assure you that we've done our best, but time's up. Time's up. Now, you're probably thinking, he's going to put implants now. I'm 100% sure. So how many of you think that you're going to put implants? Even write the notes. Natasha, is there any notes up there? Anyone making comments? How many of you considered implants from here onwards?
No comments at the moment.
No comments? Okay. I like to hear comments. I like people to talk about. It's important. But let me go next slide. So patient wants a fixed option, okay, of treatment. And when I'm looking at this case, you know, I get all the clearance from the periodontist and my hygienist, who's done a marvelous job in maintaining those existing teeth. And the mobility is actually about 1 now because it's improved, and you know, and she's not a bruxer. I mean, that saves the day. She's not a bruxer. We also have an adequate restorative space where it's an implant or tooth supported bridge work. We get good clinical crown height, and even if mobility is more than 1, you know, we can do a lot of things for this patient. Now, if you notice that I'm not talking about perio at this stage because all the teeth with perio involved are just about gone. These teeth are pretty stable now. Okay, so she's able to clean them very, very well. They're very stable. So the question is patient's concerns and live function aesthetics, reduce cost, minimize problems. And my concerns are, you know, what would you consider? Would you consider implant supported fixed full arch? Or implant supported fixed partial bridges, anterior and posterior? And would you use a tooth supported bridge work anterior and posterior, and anterior and implant supported bridge work posterior? There's a number of options to give to the patient. But one thing we can talk about this is, I mentioned this early on before we started the seminar, is that this is a landmark paper we should all be aware of. We follow about 600 patients over 202 years average, and they realized that people have well-maintained group, and few incisors and bicuspid lost. And the ones that are really severe downhill group, they were the same pattern of tooth loss, okay? In other words, no custody lost, okay? And some of the premolars remained. So provided we have this patient who we can maintain key teeth, and I'll bring another reference to teeth, you know, the teeth most resistant to loss were the mandibular cuspids and first bicuspids. But if you have the upper cuspids, they're just as good. So this is important landmark paper. So before we go ahead and try to remove teeth and do full upper arch implant, because a lot of you have gone to these all-on-4 courses given by gurus. Here's the case: get rid of it, cut the bone, get your platform right, get your guide, put the implant drilled, make sure you got blood irrigation, put them in, away they go, make your 30, 40 grand. Well, fine. But as I mentioned something early on, if the patient is not able to adapt to your prosthesis, what you going to do then? No going back. Remember one thing, implants are either 100% right or they're 100% wrong. There's no halfway. There's no halfway in treatment using dental implants. We have to plan carefully. Also, if suddenly a patient loses the implants, loses key amount of implants, you don't have a problem with prosthetics, which is a failure of the implants and prosthetics. but you have a problem of further bone loss because she has not a lot of bone. She might have it, yes, I agree, but there's not a lot of bone left. So you lose an implant, you lose a lot of bone. So where's your next step? Is the patient being informed that implants can fail? And did you inform the patient that implants can fail? So when you tell me implants are 99% successful, I say, great. Can you show me the data? It's only about success for the first year. Nobody talks about the second, third, up to 10, 15 years, because I've done implants for over 25 years. I can tell you things do fail, and there's a gradual bone loss. We like to show the best cases, but I can show you my worst cases. That's where I learn from. Patient's a smoker. She's a risk factor. Even though she signs on a piece of paper, the fact is I have a good distribution of teeth to decide what I can do next stage. I can either place implants anteriorly, do some posteriorly. In a case that we have a bone loss, I can hook across, so we can put some implants here and here and there. In the case you lose those teeth, you can't have a chance to go. That's fine. That's one way of doing it. That's one way of doing it. Okay. However, patient wants to reduce costs and maintain biology. So when we think about this, it's important to understand that when we talk about fixed option of tooth replacement, this particular place is an ideal. And I'll show you the paper in a minute by almost 30-year study using the most periodontally compromised teeth. And you can see that when we take impressions for this patient, we block out the undercuts, and then we take a mold to make it temporary. So before they all come out, we make it temporary. And when we make it in the special preparation design, Norman Limit talked about this. This is a long paper. This is a landmark paper. And we know that this works. This is before the implant time. People worked out how it works. Swedish study. Okay, Swedes are very good in their studies. So good preparation. How do we do this? Parallel preparation. You cannot rely on those resin-based cements, and you can't rely on this concept. Okay, so we need to make them parallel to each other. Also anterior parallel. The back teeth should be parallel to the anterior mid. So this is the premolars parallel to the middle of the premolars. That gives you resistance, reduces the jigging effect, the rocking effect of the bridge. And you can see that they have to parallel to each other. So that gives me the stability, it gives me the corsage stability, okay? So really the weakest link is not the teeth. The weakest link is actually the prosthetic design in your tooth preparation, because when Lynn and I went for 300 patients in a 30-year study, the problem was more prosthetic complications than actually periodontal-related complications, provided they came every 3 to 6 months for their SPT, supported periodontal therapy. And again, when you think about the preparation of this teeth, what do you see? What do you see? Can you see? Anyone can make a comment what you see here? I want to hear comments here. What do you see?
Nice looking gums.
Nice and perfect. Periodontal health. I agree. What else? A hint. Where's my margins?
Supragingival.
Very good. Okay. Have I talked to you about this case or what?
No.
Good. Okay. What sort of margins do I have? What sort of margins do I have?
Dr. Sakis,
Yes.
there was a comment by Neetu Geeta. Is this point, if this PT was to start I don't know how to pronounce that. If you can read the chat.
It says if the patient was to start bisphosphonates, how will you change your...
Yeah, the treatment plan.
Well, I will not change my treatment plan. It's exactly what they need. This is actually ideal for patients with anti-resorptive medication, especially bisphosphonates. Okay, patients with probably acting with the implants, still I would consider this as a first option. But probably you can do implants, but you have to look at the endocrinologist. You have to decide that timing is really important for implant placement. But I will still maintain teeth. Teeth are crucial. These teeth are the #1 crucial thing for this patient. Let's go think outside placing implants, and I'll show you that. Okay. So what else? So model is more than one. Okay. And part of the bridge work design is cross-arch stabilization. So not just in unilateral, you're going right across the arch. Okay. and I'll discuss more on this when we do the postgraduate diploma. All the students doing the diploma course, postgraduate diploma in prosthodontics and dental aesthetics, will have full access and understanding how the treatment is done, how to make those margins, what to look for. Okay, this is critical. This is important. This is a life skill we should teach to our students who are already registered in a college. And when we look a bit more here, for instance, okay, so good gums, I agree with you, Dr. Namesh, and your supergingival knife edge margins, I agree. Okay, let's look at the intervention. So furthermore, okay, people say, well, what about cantilever bridges? I can assure you that there's a landmark paper also by Lulick and his colleagues, it's very important names here with Klaus Lang and as well, and they got Giovanni Salvi, and they discussed a good review of the paper. You probably heard of Anti's law. Has anyone heard of Anti's law? Anyone?
I heard the name, but I don't remember it.
Well, Anti was an American dentist who wrote the 1926 to Dental Cosmos, which became the American Dental Journal, ADA. And what happened was he said, if you're missing one tooth, you need to replace it by having abutments that's going to be same as the periodontal support. So there was all this double abutment cutting, like it was a big span that cut, like if there's premolars missing or a few premolars missing, they cut lots of teeth in between. And we know that that doesn't work because periodontally compromised teeth function very, very well. We got a lot of data. Now, we can talk a bit more about these cases, but we also did something else very important. We stabilized. You want to comment on this, Ehsan? Okay. I think Ehsan's not there quite, but fixed partial.
Yeah, sorry.
Yeah.
Yeah, sorry.
Yeah, that's okay. So
I'll just mute myself so that you don't hear the
okay.
background.
So fixed partial prosthesis.
Yeah.
Compared very favorably. I just copied directly from the conclusion. Okay, in patients without severe periodontal compromised dentition, it's the same success rate if the dentition is compromised as with uncompromised dentition. So in this particular case for this patient, we thought that was the the appropriate thing to give the patient all the option, and she chose to do the minimal intervention. In other words, no implants. And we also splinted mobile teeth, as you can see. There's a special zirconia split, which is a special technique we teach it to our students, how to do this technique. They learn how to bone zirconia. And my thesis was on boning zirconia, so I'm quite versed of that. But when you think about this, coming back here, I mean, you see, you need knife edge here, and you need to really maintain the integrity of the teeth. Would you put zirconia crowns here? I mean, how much destruction do you have to do to place zirconia crowns? You never get the fit that you want, okay? And it'll be a nightmare. I mean, this is around the bifurcation area in the premolar, if you can see it. So it's something that you have to think about. There are gurus out there who just worship zirconia crowns or zirconia. Well, I'm showing you cases that zirconia is simply not an option. You can't do Emax here, that doesn't work. So this is a stabilized periodontal. You have a lot of bone loss around here, but still stable and healthy, okay? The attachment levels are low, but pocket levels are very within normal limits. So we split those teeth. Does anyone can tell me why am I splitting the opposing teeth? Why am I splitting? Why don't I let them loose in the air? Isidoro.
I guess to stabilize the occlusion and its effect on the opposing arch that you are working with.
Very good, very good. Stabilize occlusion. Okay. We can also talk about centered occlusal trauma, which you're reducing. It also improves the patient's comfort. And the other thing is also helps you to design your maxillary bridge work. Thank you very much for that. Appreciate your comments there. Okay. And so then we go ahead and design our bridge work. Okay. And you can see that where the distal pontic is, it's not touching occlusion. I want to reduce the cantilever, rocky movement. You have a good occlusion from here and there. That's actually be functioning as opposing arch. The low arch, basically very minimal contacts, just on during the really maximum intercast patients. And we have guidance, which is a very, very important to understand how the guidance works on this periodontally compromised patients. So my aim is no inflammation, so that's your design your prosthesis. We want to maintain stable attachment level, that it's always constant clean margins and periodontitis, and you achieve stable bone level. And we cannot control the responses of the biology. I mean, we're trying to help the biology. We can't control the responses. And in many ways, we go back in the mouth and we do the prosthetic, gingival tinting, trying to get as much effect as we can. And you can see that this is my gold margin here, just by gingival. I don't want to go near it. I don't want to go near it. I have adequate height. I don't have to hide. Patient has been informed that we have to do this. There's no question about that. We just have to do this. You can see how we can create optimal outline. We knew this design from my original gingival composites. So the guided position of the gingiva, and the technician had no guessing game except to create the same guide as I did a few years before my gingival composites. So everything's done with a good thought pattern to achieve the best possible outcome with minimal intervention for this patient. Now, any questions on this? Or you want to proceed next slide? No questions? Well, let's look at a CT scan. Okay. So we talk about why do I need risk assessment? Okay. Why do I need risk assessment? Okay. And this is important. Okay. Because the reason I need risk assessment is because risk assessment is a continuous process. Just because we place restorations doesn't mean that's the end point in time. We risk assess at a patient level, tooth level, gum level, bone level, prosthetic level. You see, things will change with time, which you as a clinician have no control. People are living longer. You have to think of the consequences of your actions. You think of the consequences to the patient's quality of life because of your actions. Okay, not a quick fix situation like people tell you. They will show you on their Facebook, DPR, or other channels how perfect the work is. You just cut the teeth, remove the bone, put the implants, and get your technician to make some beautiful prosthetics. That's fine, but there's a consequences. So our patient is well versed of the consequences. She understood what I explained to her. She chose minimal intervention in terms of preparation, the bridge work, and you can see, although we have considerable bone loss, but this is very, very stable. Okay, there's a good correlation around stability. Would you like to comment on this, please, Ehsan? There's some calculus here I can see also. That will be cleaned, but that's what it is. Are you there, Ehsan?
Yep. Can you hear me now? Yeah.
Yeah, I can hear you. Yes.
Yeah. So what I can see here, massive bone loss, and if you ever want to go down the path of implants, it's going to be it's not going to be an easy implant case. So I would definitely favor retaining these teeth for as long as possible. And once implants are placed, the maintenance of those implants is going to be an issue because they're going to be pretty sort of deeply placed, and as we lose the bone, we lose the carotenoid tissue, as the mucogingival line is basically genetically determined. So so this patient would require some sort of soft tissue augmentation down the track if they want to go down the path of implants, for those implants to be maintained. So a lot of consideration.
Patient's 59 years of age now. She's 59. She's 59, and we went from age like I think 45 to 59. And you finally decided to place this bridge work. So what does it tell you? I mean, just
that's 15 years of 15 years. That's quite a long time to be able to maintain function and aesthetics in a reasonable way. And implants are always an option, but I think that's what you have done here is really a great service for this patient.
Thank you.
Beautiful pink porcelains, by the way. Yeah,
Thank
nice.
you. I do work with some really good technicians. Now, when we talk about what is your occlusal prescription, see, it's very interesting. Occlusion is not well taught in undergraduate level. It's very complex, but yes, it's very simple. And the 9mm talk about role of occlusion in periodontal disease and the biological rationale for splitting in the treatment of periodontitis. When you split, you improve the stability of the teeth, and provided as reduced plaque, they'll all firm up. If you have a mobile teeth and there's plaque, I think Sopransky talked about it, you have immediate, and Lindy talked about it, you have immediate, bone loss, especially for bony type of bone loss. And so we teach our students how to do the occlusion prescription so it maintains stability of this bridge work and all the different areas of it. And this is taken recently. This is freeze and function. And she's doing very, very well. So from my point of view, I believe that 9mm has got 30-year studies, okay? And you can look up this paper on the internet, but it's incredible what a good traditional dentistry can do for our patients, okay? There's a lot of patients who don't want implants. They'll be happy to take this on, but you have to know how to prepare. That's a key, okay? So what preparations do you need? How to create resistance, not to rely on stupid resin cements, okay? How to create resistance. There's all cement with zinc phosphate cement, by the way. Look at my gum margins. You can't argue with it. I mean, are you happy, Hassan?
Pretty good.
All right, they're also gingival. Patient knows. You take a chop option. Okay, I'm not going to hide them. Supragingival.
No.
Okay, there's no question about that. And when you get occlusion, how do we get the occlusion right? How do we balance it? Here's a zirconia splint at the back, and Linda's famous paper in 1977, I think, did the job. And as I explained, we talk about what is your occlusional description, the contact pattern. What do you see? You know what I mean? Okay, and then the reason why we stabilize lower arch, as the colleague earlier mentioned, I agree with you, and thank you so much for your comment, because if you stabilize this, you can create the anterior guidance, reduce the forces on the lowers, reduce the forces on the cantilevers, okay? Because this cantilever is fine, can take the load with good teeth opposingly, but you want to reduce the force on cantilevers and posteriorly. So in this way, you improve your occlusal force redistribution, reduce forces, that's a key, okay? And maintain patience. Now, I'm not going to bother doing some cervical restorations here. Don't even think about it, okay? Don't even think about it. We'll maintain this patient. If later on, I mean, she wishes to do something about this promos with your free gingival grafts, I think you need that before you do any connective tissue grafts, I believe. Is that correct, Hassan? You might do free gingival, then you do the connective tissue afterwards. And then that'll be an option for the patient. That'll be an option for the patient. Here's your final x-ray of the OPG for this patient. And, you can see that this teeth are just in the bone. This is about still there, with mobility, but still fine. There's a bone level still there, attachment. There's mobility, we lost that one. But overall, okay, it's fine. Here's a splint, bolted, okay. The patient's feeling quite comfortable. The key is giving the patients that comfort that they can confidently get on with their lives, get on with their work. I can later always put implants if I need to. My patient understands what we are faced with, and she assesses risks. Now, you might ask me a question, why I'm not consider telescopic crowns and can remove and I could, but that involves lower field destruction, and I can't afford to compromise the core of the abutment teeth. Hence the reason why. This is zinc floor cement. It's not bonded, purely friction, because I know how to do a proper classical resistance and rotation form, okay? So that's the key to the success of this bridge work, special preparation design. And naturally, you want to see the final work, and that's the final smile line. She is smiling quite high, and it is what it is. I don't know any Photoshop of my images. You can see the patient, and she's extremely happy. She was going to do a video recording, so I can show you all, but it doesn't matter. So really, all we are doing for our patients with compromised dentition and structural support is we are simply buying time. We are buying time, and this is the key to the good dentistry. It's simple and effective, well thought process. Not because I did this, but all my colleagues who are prostheticists, I'm happy to get your comments if you're in the webinar, but it allows you give the patient a choice and look at the outcome. Not only that, we've maintained proprioception, we maintain skeletal bony outline. Where it's left, patient can function better. With the implants, there's hierarchy of perception. Okay, I have implants in my mouth. Let me tell you, I can't feel them. It's like a, you know, I got front 4 or 5 of the implant support. It's like biting on the steel. Okay, so that's the last option. Okay, I know a few of my very, very well-known colleagues who chose ME session instead of implants. I'm an implant surgeon, and I do implants every day. That's not the issue. But what is right for the patient is the key. Having said that, can you remove that, Kevin? Can you remove that?
Yes, sorted.
Okay, now, what we talked about is why still know how to plan for results and not for procedures. So as long as you can understand this paradigm, this philosophy, which is a college's philosophy, and that's wonderful to talk about this, because you are talking about procedures, which is not really what the patient wants. You want to know what the result is going to be. So this is a new upcoming course. Those of you who want to, you know, people ask me, well, Sarkis, how do you do all these bridges? How do patient comes in and, you know, how do you follow bridges? How do you make this patient go from here to there? I'm just going to play you 2 videos. Is there any questions before I play the video? No?
I think for those 2 papers that you quoted, which are really key papers, both in, you know, in perio literature and which have significance, you know, for pros and basically all aspect of dentistry. I think they really have to be part of the reading list of the college. I'm sure that you've already. Yeah.
It is a part of reading list, and I can assure you that reading list is a must in terms of what we see. And you know, I mean, I couldn't agree more with you in terms of how do I explain the concept of helping the patients and helping the students to rely on you know, the world literature in making their everyday decisions. Because if you remove those teeth,
yeah, there are not many paper. I mean, still the Hirschfeld-Wasserman is 1978, and Diamond and Lindy 1978, 1979. It's still, you know, 40 years ago, and we're still quoting them. And as a perio postgrad, I needed to know, you know, the ins and out of the paper, and basically every bits and pieces. I'm a bit old now to remember all the details of it, but it's just very important papers that just demonstrates basically how the traditional dentistry can work very well if done properly, and how teeth conservation and preservation is can be achieved in well over 30 years.
Absolutely. You know, Hassan, if a patient comes in and dentist decides to take all these teeth out, place implants, as an implant failure, the patient is happy. And we get these cases, and I say, can I see a perio chart? No, I haven't got a perio chart. Okay, what were the teeth like? Oh, they were all right. Well, I can quote this paper to the patient, and the case just falls apart because patient says, I didn't know I could have bridges. You see, and there's a good paper because this works, and we know it works. But because there's a lot of people there, and implant companies love this, to pull the teeth apart, put implants in. You know, to me, that's just no. I mean, who are you doing? Are you promoting the company? Are you sold out by the implant companies? Or you're a really good doctor that you want to do the best thing for the patient? I mean, I know which one I would take. And this is an important part of treatment planning and decision-making process for the patients. You know, this is serious stuff. You're playing with people's lives and their confidence, their biopsychosocial well-being. It's just not a joke. You You know, that's so important, in my opinion. I just want to play 2 videos, if you don't mind, just quickly, if that's okay. I just want to do it. So sorry, sharing. I'm just going to play a video. Give me 1 second. I will then. I'll just add this. I apologize. Hang on a second. That's 1, and I'm going to get the other one. I won't be long. Just bear with me for a second. I won't be long. It's case 2. Hang on now. Composite, case 2, case 1. I'll show you the video as I'm discussing it, and then I'm happy to take on any questions you may have. Okay, now I will share. Hang on now. Share screen. Okay. Just 1 second. I need to do that. Apologies, I'm just trying to share the screen now. And I'm almost done. Okay. Almost done. Just 1 second. And we're going to share screen. Which one is this? One second, I do apologize for this. Okay, PowerPoint. Okay, that one comes out. Moving up 15. Okay. No, we're not share. Can you see that screen? I'm just going to play the. Can you see this?
Sarkis, how do you fix those complex work by doing simple composite restorations? Well, that's a really good question, because let me show you a scenario. Here's a clinical scenario. The patient comes in, you can see, as your periodontal condition is quite good. Can
you see it or not?
For right, central and lateral incisors.
No, we can't see
Oh,
that
1
video.
second.
Now, her concern is
One
that
second.
that keeps failing.
Let me do this.
And she comes to you for a solution. Says, look, my
Can you see this?
budget.
Yeah. Now, right. Yeah.
Good. Thank
I'm
you.
often asked, Sarkis, how do you fix those complex work by doing simple composite restorations? Well, that's a really good question, because let me show you a scenario. Here's a clinical scenario. The patient comes in, you can see, as your periodontal condition is quite good, and there's a missing upper right, central and lateral incisors replaced by Merlin's bridgework. Now, her concern is that keeps failing all the time. And she comes to you for a solution. Says, look, my limited budget. I really can't afford implants. And you probably think in your mind, implants are the best solution here. But, well, there's other solutions. And this course is about looking alternate solutions that are just as predictable. Okay? So what I can think about is this patient issue presented. She was referred by a colleague. Look, can you just look after this patient because there's other issues available, etc. We said, okay, fine. But we can think in terms of how do we treat those patients in a very simple and effective way. So if you look at this patient's smile, for instance, she's right here. She's also concerned about the smile. You know, she's not at a stage in her life where she wants to look good and feel good. It's very important to look after our patients at these stages of their lives. Someone has said to my patient, "In what stage in your life are you?" And people say, "Look, I really want to look good. It's that time where I look good and get in my life." So that's what we did for this patient. So we took this patient from here in one visit using direct composite build-ups, okay, and a few other things that we talk about during the lecture naturally, and went from here and went over there. And we can teach how you can do this for your patients in your practice.
Okay, just go to the next one now. Just give me 1 second. I need to get my act right. And you go to the next one here.
Now,
can you see this or
another
not?
clinical scenario?
No.
Patient presents in your practice.
No.
1 week after a bike accident.
Can
Here's
you see
another
this?
clinical scenario. Patient presents in your practice 1 week after a bike accident. You can see on the images provided that we have loss of left central incisor, there's fracture of the lower central incisors and upper central incisor. When you take an X-ray on a CT scan, you can see that there's hardly any bone that's available. So the question is, in your mind, what you're going to do. okay? If you think implants, well, think again, because this patient needs to have immediate aesthetic and functional needs that needs to be treated. So in this lecture, we'll talk about how do we take care of these trauma cases immediately? How do we restore function and comfort and aesthetics as soon as you can? So with the composite technology, today, which has come a long way, and this is a more than 10-year study, by the way. So you can see that we went there from here, and with a simple procedure as the patient presents, in one visit, we went and started five bonded resident bridge work, and we build this, and every time you can see these steps as it comes on the screen, and naturally you're able to improve the patient's anterior aesthetics. So today, the choice is very simple. People want effective treatment, okay, and minimal intervention to get into the line, to get care of their life, to improve their quality of life as soon as possible, while we plan long-term treatment for this patient. So we do this patient immediately from here, okay, to there.
She still has the same clothes.
We'll be teaching you how to do this in your practices. It's simple and effective, but we just have to know how to diagnose and look at the important factors that you need to assess before you go to the next stage. And if you're really interested in learning how to do this, and perhaps this course is for you.
Okay, any questions? I'll just go back to the college again. Okay, any questions?
Dr. Sarkis, there's a question regarding this 2-day course from Dr. Gary. He wanted some more information on this 2-day course, and for each module, what does it entail?
Well, diagnosis of orthography is a very important part of it. People say, I know how to diagnose. You know, can you just do the occlusion for me? Or can I do the tooth frame management? Or can I do pros? The answer is no. And the reason is because take good photography. If you like the images that I've taken for this patient, I'll take all my images. Because what the eye cannot see, as I wrote this a number of times and we quoted the DPR, is what the eye cannot see, the mind cannot recognize. I mean, I've been saying this since King College time back in 2006, and I wrote the papers for the college. Now, the important part is that we teach you, like all the pictures you see, and those of you who have got the prospectus, they're all my images. I've taken all of them. All the images I've taken of me, except well, myself, and I had this model taking my photography, but that's not the issue. All the rest of the images are mine. I've taken them. So who is better to teach you about photography than me? Because I'm the one who's taking those photos. So as a clinician, I'll tell you what to look for, what to see. Not just looking and seeing are two different things, by the way. Okay, you can look at the same thing, I see two different things. Okay, and also how to take good images, and that's a key. Good images is the most important part of diagnostics. Okay, and then we'll teach you how to get information. It's all in your pamphlet. Now, treatment planning is we're going to teach you how to catalog information in a PowerPoint format. So you will have to present about 5 cases each. And there's no problem for you finding. If you have less, doesn't matter. When the next 2-year program, you'll pick it up. And then imagine, let's say we got number of students times 5. Everyone's watching each other's cases. Wow, what a learning atmosphere. And you have multiple mentors. Okay, look at interdisciplinary way of thinking. You start thinking like a specialist. When you start thinking like a specialist, you're not practicing like a specialist. Okay, even though with occlusion of TMD, I don't like putting TMD next to occlusion, but everyone thinks like, so I said, well, so be it. Composite reconstructions. I mean, that's a wild area. You know what? If there was no composite today, so to say, dentistry would be gone. Composite saves the bum of dentistry, let me tell you. Okay, absolutely. Paraplastics. This is where some will come in and study dentistry. Minimal intervention after 15 porcelain technology. And now I have talked about this so many times. And people are so in a rush to go and publish some papers, but we got over 25 experience in here because I've in my laboratory we developed this concept. Fixed prosthodontics. I mean, this is your bread and butter. This doesn't change. Okay, not bondodontology, it's fixed prosthodontics. Okay, removal prosthodontics. Now you gave this away, you know, the dental board gave this away about 25, 30 years ago to dental prosthetists. And they're saying, oh, they're going to do things cheaper. Now they charge more than dentists do. So if I bring this modality back in your practice, look what's going to happen to your income. So, course is 25,000 plus GST. Let me tell you one thing. The amount of return, the ROI, return on investment, is going to be huge for any clinician who's dedicated. Now, you're not going to get this for nothing. That's about paying the fee. You'll be examined. You're going to write assignments. Okay? I'm going to build you up to that new level of confidence with my colleagues. Okay? You're going to read papers. You're going to understand how to criticize paper. Okay, we'll talk about implant prosthetic surgery planning. That's all is in line. You see, you can't do this without doing that. Have to make you rethink. Might be have to change your paradigm. You have to think different with me. There's a philosophy of treatment. What's best for the patient, not for you as a clinician, but what's best for the patient. And the consenting process is not your opinion over the patient. Consenting process is what is the best for the patient. You have to think, if you're the patient, what's best for you. You have to explain to your patients. And you got dental prosthetics and you got full mouth reconstruction. So by the time you come here, you know exactly what to do.
There's another question regarding the course as well. One from Wiki, and he's asking that if there's a lockdown, how do they do practicals? Can they attend the lectures via Zoom? And Babita is also asking where are the face-to-face lectures? What's the location for face-to-face lectures?
Face-to-face lectures is either in my surgery or at EOD or with Derek, depending on what we have, the situation. And probably the diagnosis will be in my surgery photography, because we have whole camera set up where you'll take a photo, go on the screen, we can do this of affect and criticize a photo, and you'll be taking each other's photos. So you will be, see, I need to get your photography, your information gathering skills, how to look for, what to look for, periodontal caries, diagnosis. I mean, the problem is, let me give you a scenario. One of our patients returned from Queensland. Her niece is a dentist. She fractured a little tooth, so immediately she went and did a, CEREC crown, okay? And she missed the caries. I mean, how can you miss a caries that's next to the CEREC crown? So that's what I'm trying to tell you. They're planning for procedures and not for results. You actually miss caries, which is a DOB caries. It was incredible to see that. I had to point this to the patient. I said, there's something wrong with the education system, okay? We all procedure-based. We don't think about, hang on a minute, let's look at the whole mouth. How to restore, so diagnostic photography, in the treatment planning, you're going to learn how to restore the mouth to health before you go next stage. So people rush. You see these crowns that should be done, you see this veneers to be done, and you're sort of drooling, and you can't wait to just jump in and do it. Just wait, stop. Have you seen other factors? And I'll be pointing them out in your cases. Then you start thinking back, hang on a minute. It's time that I change my paradigm. And that's an important starting point. So to answer the question in terms of, we have my clinical setting, we have 5 surgeries here, full setup, you learn clinical settings. Now, if you're in Melbourne, we have Zoom, we have one-on-one, we have about 20 hours in between every 2 months with the modules, where I'll be talking with you, discussing cases, and there'll be some one-on-one sessions to be able to help you to criticize the knowledge. You all have questions to ask. There'll be a lot of questions. They all come in different levels of clinical practice. By within 6 months, you'll be all the same level I can show you. Then we'll build you up from there. Sometimes it's important to say, the old saying, Einstein said, what did Einstein say? He says, it's what we know that stops us from learning. That's a powerful statement.
Yeah. There's another question regarding the course again. I noticed you have interest-free loans available. How does that work?
Well, what's the name of the company that does the loans?
Credible.
Yeah, Credible. Yeah, Credible. We organise where GST is deducted, so that allows you to pay interest-free payments, and that they'll talk to you. Sandy, talk to Sandy. She's organised. Most students have signed up already because that's a viable deal. And you can come at certificate level, and you can come, after 6 modules, you can upgrade to the diploma level with a difference, because we're happy to do that for you. Yes, that's fine. So that's not an issue. And she's most accommodating to the finances.
We missed out a question regarding the seminar today from Ken Ravi. He was asking, would you extend the posterior cantilever up to the 6th or the 7th?
Sorry. Okay, this is a good question here, right? Let's get, okay. Okay, let me rephrase this for you. The answer is I could have, but I chose not to. Here's the reason. Because she's been functioning well on those shorter than large, there was no reason for me to add any more stress on distally, okay? Because full smile accommodates the smile aesthetics, reduce the further cantilever, you know, on an already stressed situation. So from that point of view, I think this is the other one, isn't it? From that point of view, I mean, also this is highly compromised. So we split this teeth together. So if I extend it, we might end up losing this one too. So, you know, the lower molars are really important for actually lower patients who's, you know, in the aging process, especially females, to hold their cheeks. Okay, so when you lose that, her face collapses. So that's one reason. So having said that, good idea, but a patient been functioning in this situation for a long time. So I only added one more tooth here, and I think that's good enough. But good question. Thank you for asking.
There's another question from Alan. He's asking, are we able to discuss our own personal cases and get advice on treatment planning and clinical skills during the course?
Absolutely. As a matter of fact, we throw those cases on board if you want other students to share it, because you see, knowledge is about sharing and seeing other people's experiences, because there'll be so many questions arise from all the other clinicians in the course that you probably had the same question to ask and forgot to ask or do you want to ask. So I believe that that's an important part of the whole, the camaraderie of being part of the college. So when you're in a college, you are accessing a lot of information, a lot of knowledge, and that's really important. It's the motto of the college is to teach. We'll hold your hand a little bit, but we can actually push you to think. That's important.
Sarkis, I might say goodbye to everyone.
Okay, thank you, Hassan.
All right. Have a good night. Cheers. Thanks for having me.
Thank you. Thank you.
Okay.
Thank you very much.
Thank you.
Any other questions? I'm happy to help.
Dr. Sarkis, I'm just going to add to what you just said about sharing the knowledge. Now, not just being one of your previous associate, but being a general dentist for last 11 plus years in Sydney, I would like to add to all the colleagues that are listening to this webinar that I've done a lot of courses in Australia in last 15 years, and I'm general dentist in Sydney for last 16 years. And I've been lucky enough to be an associate with Dr. Sarkis as a new graduate. So what I have observed in 15 years in Australia, there is plenty of courses. We got plenty of choices. We got a lot of great clinicians out there, but there is very rare, or actually not many at all, who love to share the cases, who would like to share the success and failures both. I have found Dr. Sarkis so helpful till today that pretty much anytime, even at the evening, I have got some question, he would be ready to help. Send in just 1 or 2 lines, because that's all I need. I don't need to take any of his more professional time, but that 1 or 2 lines always helps to solve any cases that I have been doing for all these years. So if any of you looking for that 1 or 2 line help or that key help from your mentor, your specialist colleague, then I think this would be the way to start. Thank you, Dr. Sarkis, for that.
My pleasure. Well, Nimesh, can I mention, I mean, you and Isidoro have been with me for a long time. I mean, if I could say bluntly, you both run a conservative and multi-million-dollar practices by using the philosophies and principles that I've instilled in you. Would that be correct?
Absolutely, absolutely.
See, what I'm trying to say is that one doesn't have to do complex major work. You can do simplified dentistry and make just as much income rather than doing complex. But in this course, you have the choice of doing both in a predictable manner. That's the important.
Yeah, it's just like sharing the example of course, from Indian background, I would say cricket. A lot of people out there to teach us how to do 4s and 6s. That means how to do all on 4 and how to do all on 6s. But the real game in dentistry is doing 1s and 2s, because that's how you make century. That means that's how you make the runs. That's how you do your income. A lot of people out there teaching us how to clear those mouths and actually place implants everywhere. But they don't tell us that when the shit hits the fan, then what to do. Okay, so how to actually buy the time and have a backup plan in place, because everyone's living up to hundreds. And if we start placing implant in people's mouth in their 50s and 60s, I'm pretty sure that in 25 years of my dentistry career, I have seen a lot of implants failing. And of course, Sakis has seen 10 times more than what I have seen. So I think everything fails, and as long as we have a backup.
Exactly.
If we could.
Exactly. Couldn't agree more with you. That's why I talk about different ways of thinking, Nimesh, and well said. Thank you. Is to allow the clinician to understand that when you're planning dentistry, you got to look at patient's lifespan, and people are living longer and healthier. It's called the philosophy of healthy aging. This is a well-known fact by WHO called healthy aging, and dentistry is a very important part of it. If you, I've traveled the world extensively, you can see different parts of the world. A 90-year-old riding a push bike along the Rhine River, if I've been in Germany, for instance, and they're healthy, they look good, they look after themselves, and they expect their teeth to last as long. So that's something to think about before you start planning it. This is important, because if you take this teeth out, look, I have to tell you one thing. It's unfortunate, but I'll say it. Prosthodontist Terry Walton said, wrote an article, said prosthodontist carries the can when everything's failed. So when things fail, they end up here, and I'll have a look at it, okay? Not to make a judgment call sometimes, okay? And I know for a fact that when I don't want to show you, but there's poor margins, plaque accumulation, patients a risk factor and all that. And you can't just blame patients. You have to say to yourself, okay, what did I learn from this case? And I've made lots of mistakes. I have to tell you, lots of mistakes. And but that's just life. And the aim of this college is to make you learn from our mistakes, and that's to make you wiser. That's all there is to it. I think that time has come for this important bridging gap in dentistry to be taught to dentists, where you're a new graduate, you're not for a few years, or you're a highly experienced clinician, just wants to look at things in a different way. And that's what this college is about.
There's a question from Ryan. Would you apply the same principles of the upper to the lower if the patient loses her lower teeth in the future?
Okay, good question. Very good question. I would look at the distribution of the missing teeth. Okay. Now, having looked at distribution of missing teeth, I will still give the patient's choice if the premolars and canines are still there. Okay, you can still do the same thing. But also you have to understand, we have over 45 years of data on a mandibular implants, whereas the maxilla is far more complex. So I will give the patient same options and delay as long as I can before I proceed and do lower arch clearance. As a matter of fact, in many ways, I will place, if there's let's say the molars are missing and she needs to choose, I will do strategic implant placement and let the implant stay. And depending where, but you'd be surprised how long teeth last. That's the issue. You'd be surprised how long teeth last.
There's another question from Beria Ahmed. He says, thank you so much for sharing your cases with us. In the last OPG shown, I can see periapical radiolucency on the 45 and 46. Can you please comment, Dr. Sarkis?
Hang on, let me just come to that. Here, right here, in this area, okay? They're actually not periapical lesions, and also for one, they're just mobility. These people are mobile. We splitted them. Okay, they're mobile. We split them to maintain strength and comfort. That's all there is to it. Okay, and with the therapy, we can still improve this outline. But if you look at the images, where is it?
Equal pay for equal work.
I mean, the gum is healthy.
Follows the way you would like to be
Do you see that?
You respect women.
Okay, gum is healthy. So as long as gum is healthy, I'm not worried. Okay, you know, there's a past discharge, pro discharge, sure, I will do something about it, but gum is healthy. In many ways, you can do hemisections too, just if you want to enter it. That's not the issue. The issue is that this dentistry is a traditional dentistry. People do it for a long time. You know, this is almost, what, 77? How long is 77? That's 30, like, you know, almost like 50-year-old cases. These people are dead now, but they had their teeth and they died.
There's a
Sarkis, that's
question.
the one. Yeah. Sorry, Kevin, are you saying the same question from Tony about can we do
Yeah.
this course in our own time?
Of course, you
We
can
do
do
the
time. It's every 2 months. It's every 2 months. Every 2 months, and I think that's fair ask because if the module starts for 2 days face to face, and face to face is intense training. I mean, you'd be surprised what you'll be doing. Well, I'll give you the lectures over the Zoom, the lectures, but and we'll do some lectures in house as well. But I want you to get your hands wet when you're here. I mean, to use the opportunities to do a lot of practical stuff. That's really important, you know, to me. And then you're going to ask questions. We're going to discuss your cases. You're going to look at the progression of your cases. I want to make some comments. You're going to see how others are doing your cases and how to do their cases. Then you're going to look at your cases. And that's a whole learning atmosphere. You know, this is different to online learning. You know, online learning, I mean, how much can you learn from online learning? Right? My son is a violin virtuoso. Can you imagine if he did online? I mean, teacher will tell him first how to look after your violin, you know, how to respect your instrument. And then you learn the teacher to master, you master the student combination. That's very important. Someone needs to teach and hold your hand and say, do it this way. And I say, why would you do it this way? You know, I like to challenge your thought pattern because that's how you learn. Natasha will tell you, she asks me all the questions, and there's a question with a question. And then I will get the answer of anyone because I know you have the answers, but you need someone to guide you to get the answers out of you. When you get the answers, then you know it. That's what it's called the light bulb effect. You understand the concept. And we're here to teach you that. What was the question, Kevin?
That's all. I think we've addressed all the questions for tonight.
Thank you very much. I hope it was an informative lecture. And we'll send whatever required, a new short course coming in for 1 day. And thank you, Kevin, Natasha, you know, everyone who helped during this lecture. Ehsan's gone, he's busy with a young family.
Yeah.
So if there's more questions, please write to Natasha at rcotp.com. So I think you have the email. I think Natasha's got your email, so we'll happy to send them to you. Any questions, anything question that you have a case, or you want to look at the college, we'll be starting very soon. So, you know, think about it. This is the most important opportunity in your lifetime to invest in yourself.
Thank you, Sarkis.
Thank you, thank you. Thank you all.
Thank you.
Thank you.
Thank you.
Dr. Sarkis, you can end the, actually there is, it's just a thank you.
All right, okay.
You can end the seminar now.
All right, thank you. I will leave the seminar. Thank you, everyone. Thanks for joining.
Okay.